Hello, everyone, and welcome to this talk, which is entitled Exercise with Type 1 Diabetes, Finding the Right Mix. My name is Dr. Jane Yardley. I'm an associate professor in the physical education department of the Augustana faculty at the University of Alberta, and all of my research is around type 1 diabetes and exercise. So today I'm going to talk a little bit about different types of exercise. First of all, why everyone should exercise. A little bit about the highs and the lows and what causes them. So an explanation behind the hormones that are helping regulate blood glucose during exercise. Then I'm going to talk a bit about trying to find that right recipe, the right exercise, specifically when talking about intensity, the right person, and here the focus will be on sex and gender, the right time, and looking specifically in the early bird versus night owl type of exercise plan. I think almost anyone coming to a presentation like this knows really well why they should exercise. And we know from a lot of studies that people with type 1 diabetes who exercise regularly will have a lot of benefits. The first of these is living longer. And here we're not talking a few months longer, we're talking several years longer. We see a lower risk of cardiovascular disease, and where heart disease is a very important contributor to mortality amongst those with diabetes, this is a very key benefit. We see that people who are active develop fewer complications, and that's including neuropathy, retinopathy, nephropathy. So your kidneys, your eyes, your nerves are all going to be healthier. So is your body weight. And when body weight is usually directly correlated with insulin resistance, so the higher the body weight, usually the more insulin resistance you can develop, this is going to be an important thing to keep in mind when you're using synthetic insulin. Maintaining more muscle and preserving bone. These are both really key points because we have recent studies showing that people with type 1 diabetes actually lose muscle quality and strength, as well as bone density and quality faster with aging than people without diabetes. So trying to maintain these is really important. And of course, we see that people who exercise are happier. We see a higher self-rated quality of life. So the question that I always ask at the beginning of these presentations is, if a pill did all of this, wouldn't you take it in the biggest dosage possible every single day? The problem, of course, is that there are a lot of barriers to being more physically active. In the general population, the top reasons for not exercising include things like not having enough time or money, not having enough knowledge or experience, lack of results, sometimes because they're not giving it enough time. But again, these are all reasons. Lack of enjoyment. Some people just don't like to move their bodies. With type 1 diabetes, we know that fear of hypoglycemia is the biggest diabetes-related barrier to physical activity and exercise. We also know that more than 60% of adults with type 1 diabetes don't meet physical activity recommendations, and that women with type 1 diabetes are less active than men with type 1 diabetes. And this actually isn't all that surprising. We see this in the general literature that women tend to see more barriers in terms of being physically active, whether they have diabetes or not. The idea of precision medicine has been gaining a lot of steam in Canada and the world in the last decade or so. And the idea behind precision medicine is trying to find the right therapy for the right patient at the right time. And the reason that I bring this up is because we really can think of exercise as medicine and try to find the right combination to have the best outcomes for people who are using it. To do that, it's really important to understand where you store your energy that you use during exercise and how different hormones regulate access to these sources of stored energy. The first one that we see storage is lipids or fat. Most of us are very aware of where we find these, all the squishy parts on your body, that's your adipose tissue. These fat stores can also be found in small amounts in the muscle itself, and it's something that if you do a lot of endurance training, you can actually increase the amount of fat stored in the muscle to a certain extent, so that this can actually be a source of fuel during exercise. And then we see a really small amount in the blood. And what's in the blood is usually in transit. It's either going from the digestive system out to one of those storage areas, or it's coming from one of those storage areas to go to the muscle to be a source of fuel for activity. Then we have carbohydrates, glucose in particular. And what surprises a lot of people is that almost 80% of the glucose that goes into the body is stored in the muscle. And once it goes into the muscle, it can't come back out. We also have about 20% that's stored in the liver. This one can be accessed as a source of fuel that can top up blood glucose if the right combination of factors exists, and we'll get into that in a second. And then we have this tiny little bit of glucose that we find in the blood. And the analogy is a teaspoon of sugar in about 5 liters of blood, because that's the average amount of blood in the human body. So you can see that if this last one, if this blood glucose becomes a source of fuel during exercise, that because there's not much there, it's going to drop pretty quickly. The other thing to keep in mind is the difference between regular, naturally produced insulin and synthetic insulin. While they do the same thing, they're very different in how they are made and how long they stay in circulation. Naturally produced insulin, which is made by the beta cells in the pancreas, has a half-life of 5 to 7 minutes. What that means is that 5 minutes from now, if I don't need all the insulin that I have in circulation, half of it's going to be gone. If I still need the same amount, my body's just going to produce more to replace that. But during times where glucose drops quickly, if we're fasting or if we're exercising, insulin levels will drop in parallel with that glucose level. With synthetic insulin, it's a little more complicated because the levels will depend on what we've delivered by pump or injection. And we see from this plot here that there are lots of different types of insulin with different durations, but even the fastest acting insulin takes hours to clear the system. The green peak that we see here, you see how quickly that comes and how quickly it goes away. That is naturally produced insulin. These yellow peaks are the faster ones. And even now with FIASP, this curve is very similar, but just shifted ever so slightly to the left. And it still takes 2 to 4 hours for a lot of it to clear the system. So what that means is that in times where we need less insulin in circulation, oftentimes there's too much there because it doesn't clear out of the system as quickly when it's synthetic. Overall, keeping the balance, it's something the pancreas does really well if it's working properly. Eating will result in an increase in glucose. And actually, even before you eat, the nervous system sends signals saying, okay, there's food coming. And the pancreas will increase the amount of insulin in circulation. This insulin-glucagon relationship is actually really important. Insulin comes from the beta cells in the pancreas. Glucagon comes from the alpha cells. Those cells are right next to one another. When insulin goes up, it stops the glucagon production, or at least slows it down, so that you don't have these two competing hormones, because insulin's job is to bring glucose down. Glucagon's job is to bring glucose up. So when we see this increase in glucose in the system, insulin levels will go up, glucagon levels will go down, and glucose will be stored to try and maintain those stable blood glucose levels. On the other hand, when exercise starts, we'll have either, a combination of some nervous system activity and a decrease in glucose that will signal to the pancreas that it needs to decrease the amount of insulin that it's releasing. In doing that, it allows glucagon to then be let out into circulation, and the production of glucagon increases. Glucagon acts on the liver, that 20% of glucose that we saw stored as glycogen. And when it does that, it increases the blood glucose levels to where they need to be and maintains that stable blood glucose. If we put this in the context of type 1 diabetes, the increase in glucose that results from eating doesn't get a response from the pancreas because the beta cells have been damaged by the immune system. Instead, the amount of insulin that's in circulation will depend on what has been pumped or injected into the body in the hours before exercise. In the hours before that meal or with that meal, which will help bring glucose down to close to where we want it to be. But everyone knows that this is a bit more of an art than it is a science, and that no 2 days are going to be the same, and that no two responses are ever identical. On the other side, with exercise, which I started going through earlier, but a little prematurely, we see sympathetic nervous system activating here, as well as a bit of a drop in glucose, and the pancreas can't respond because those beta cells have been damaged. And we also see that with longstanding type 1 diabetes or frequent hypoglycemia, that glucagon response is completely impaired and sometimes absent. So we don't have the help from glucagon to access those sources of glucose in the liver. We don't get that increase to maintain blood glucose levels. And we see a lot of variability, both in the responses to exercise and in the body's ability to maintain blood glucose levels. The right exercise. So here we're going to start talking a little bit about intensity. Aerobic exercise is any type of exercise that involves repeated contraction of large muscle groups. This would be anything like walking, jogging, cycling, skating, cross-country skiing, dancing, swimming, as long as it's not of a very high intensity. And when we talk about intensity, there's something called the talk test. If you can have a conversation with the person next to you while you're doing the activity, that means that the activity is aerobic. It's still increasing your heart rate, it's still speeding up your breathing, but not to the point where you can't talk. During these aerobic activities, fat is actually your main source of fuel, and the adipose tissue in the body is what provides that fuel. What's important to note, though, is that glucose is the second source, not the 99.5% that is stored as glycogen in the muscle or the liver, but the less than 1% that is stored in the blood or circulating in the blood. The important thing to note is that the key hormones here are insulin and glucagon, and that if insulin levels are high, that it is going to cause the body to be storing glucose at the same time as glucose is being used for muscle contraction. If we look at what normally happens during exercise and what the body's designed to do, exercise usually results in a decrease in insulin. But with type 1 diabetes, because we're depending on the insulin that was previously pumped or injected into the body, we tend to not see that decrease. In fact, because insulin being injected or pumped tends to accumulate in a little depot under the skin, an increase in activity, which increases blood flow to the skin, can sometimes show an increase in insulin in circulation during exercise. So pretty much the opposite of what we want to see happen. Where we want to see glucagon go up, often with type 1 diabetes, it does not. And as a result, what we tend to see with glucose is a pretty big drop, somewhere in the range of, I've seen as big as 5 to 8 millimoles per liter in a single exercise session, depending on how high glucose levels are to begin with. And this has led to the recommendation that there be a focus on adjusting insulin before exercise, especially if you are going to be performing aerobic exercise. And there was a very nice series of 2 studies that came out of the UK. Here on the left, they gave the participants a snack at time 0 here, with which they gave an adjusted bolus of insulin, or, well, in one instance, they gave them a full bolus. In another one, they gave them 75% of the regular bolus. In the third one, 50%, and in the fourth one, 25%. They mixed up all the sessions so that they were done in a different order, but all of the participants did each one of those 4 sessions, separated by a few days. And what we can see is that when the full dose of insulin is given, glucose isn't quite as high before exercise, but the drop in glucose is pretty big during exercise. That's what this bottom one is here. And on the other end of the spectrum, with a 25% decrease, we see that glucose is a bit higher at the start of exercise, but there's also less of a drop here during this particular exercise session. So based on this study, the researchers thought that, okay, maybe only giving 25% of the regular bolus was the right way to go if there was a snack before exercise. But then they wanted to see if that changed depending on how long after the snack exercise took place. And that's what we see over on this right side. And we see that if exercise is taking place 2 hours, so 120 minutes after the snack, this is what produced the biggest drop in glucose. And that kind of makes sense when you think about how long it takes for insulin to peak in the system, and in particular with the type of insulin being used in this study. The timing might be slightly different now if you're using a faster, like a Fiasp or something like that. It would just sort of shift that time a little bit to the left. The important thing to keep in mind here is that this shorter time, the 30 minutes before exercise, it's actually, it works quite well with the type of insulin that was being used in this study. And that was because there was glucose coming from the gut into the blood during the exercise session, and the insulin hadn't quite hit its peak yet. So the bottom line here is basically whatever insulin you're using, you might have to play around a little bit with when to adjust it and how much to adjust it before exercise if you're taking a snack in order to see the best outcomes and the least risk of hypoglycemia during exercise. If you are not eating and eating before exercise and you'd like to try something different to try and maintain your blood glucose levels because you didn't have time to adjust your insulin or you forgot to do it, another option is to add high intensity to your exercise. This is a study out of the 1980s that showed that a really high intensity burst here of about 10 minutes caused an increase in glucose in people with type 1 diabetes. Those are the open squares here, and people without type 1 diabetes. But we see that after exercise, those without type 1 diabetes, the glucose levels go back to normal, whereas they actually continued to increase in people with type 1 diabetes. One thing to note, and it's something that's only recently starting to be recognized for its importance, this a particular study, the participants were fasting. And I'll get back to that when I start talking about early bird versus night owl later on in this presentation. So if we're going to add high intensity, what are your options? One option that we've looked at is resistance exercise, because even though these are done in short bursts, you're using very forceful muscular contractions. And so it's considered what we call an anaerobic activity, so a high intensity activity. This would be the same as if you were doing intervals where you sped up your speed or your effort to a really high level for a very short period of time and then came back down to a recovery pace. The reason why it's different when you add these high intensities is because now instead of using fat and blood glucose as your first two sources of fuel, you're using all of that stored glucose, the 99%, the muscle glycogen, the liver glycogen. These are now the main sources for your high intensity activities. And the reason for that is that you have different hormones that come into circulation when you do these activities. Epinephrine, otherwise known as adrenaline, is part of a survival response. Um, uh, I'm having a hard time remembering now. The fight, flight, or freeze response, there we go, is where we see epinephrine coming out. And basically what it does is it allows us access to a lot of energy very quickly while speeding up heart rate, speeding up respiration, essentially giving us the ability to run away or fight if we need to. And that survival response has an impact on blood glucose levels because, of course, that liver glycogen can release glucose into the bloodstream to help maintain glucose levels during exercise. What we see in this type of activity with weightlifting, here's one study that this was part of my doctoral research. We saw what we expected with aerobic exercise, where there was a pretty big drop in 45 minutes of running on a treadmill. 60% VO2 peak means that they were running at a pace where they could still talk more intermittently. It's not an easy pace, but it's also not a very hard pace. And here with resistance exercise, we still saw a bit of a drop in glucose, and that was performing 3 sets of 8 repetitions of 7 different exercises that targeted all muscle groups. So wasn't an increase, but it was less of a decrease. We also saw that if we use that resistance exercise and put it in front of an aerobic exercise session, so that's what we see with the closed circles here, that this is resistance exercise, just a slight decrease in glucose. But when we did aerobic exercise right after resistance exercise, that drop in glucose didn't happen right away. And it wasn't quite as pronounced as if the aerobic exercise had been done without that resistance exercise preceding it. Whereas at the opposite way, that drop in glucose was there right away with the aerobic exercise when it started, but it seemed to stop that decrease or that drop in glucose if resistance exercise was added right afterwards. One thing to keep in mind, though, if you're doing these higher intensity activities, is that even though that risk of hypoglycemia may be less pronounced during exercise, we tend to see a higher risk after exercise. So here, this is the same study that I was showing before with the resistance exercise. And we can see that about 6 hours after exercise, that there is a lower average glucose than when aerobic exercise was performed. And this can be problematic because if that exercise was performed later in the day, which it was in this particular study, these lower glucose levels are happening somewhere around midnight, 1 o'clock, 2 o'clock in the morning. We have a similar thing happening in this study on the right. Here, this was a high intensity interval exercise study where participants did 1 minute at a higher intensity, followed by 4 minutes at a lower intensity. And what we can see with this one is that the meal post-exercise gets the same peak in glucose that we would expect, but the overnight part, we see that the highest intensity exercise, that's what the grayish blue color is here, the highest intensity exercise was associated with the lowest blood glucose levels overnight. And this makes sense if you consider where that glucose is coming from, that these storage areas of glycogen in the liver and in the muscle, they need to be replenished after they've been used during exercise. If there's a meal right after exercise, the liver tends to top itself up right away. It's a bit of a hog. And that leaves the muscles to gently suck glucose out of circulation until they are done replenishing those stores. And oftentimes that can happen for up to 12 hours after exercise. And if that exercise is later in the day, then those hours are happening overnight, which again can be problematic. The right person. Well, here the focus is on sex and gender. We know that women with type 1 diabetes are less active than men with type 1 diabetes, but this isn't surprising because we also know that women in general are less active than men. They see more barriers to exercise and physical activity. Fear of hypoglycemia and increased glycemic variability are the major barriers to exercise that are associated with type 1 diabetes. Males and females use different fuels during exercise. And this is basically based on studies of people without diabetes that show that female participants tend to rely more on fat as a fuel source during activity, whereas males tend to rely more on glucose. Men and women also have different exercise preferences and behaviors. And this is, again, not a very surprising finding. Here I say potential sex-related differences because the only study that's been done on this is a secondary analysis. What that means is that we took data from two different studies that were designed for a different purpose, but we were able to split them in male and female and compare what the blood glucose responses were. And here we can see that in this particular set of data, the male participants had a bigger drop in glucose than the female participants, who actually didn't really see much change in their glucose throughout this weightlifting session. And it was the same type of exercise that we had seen previously, the 3 sets of 8 repetitions of 7 different exercises. And if we follow that glucose into the overnight period, we see that females tended to have higher glucose levels for a few hours after exercise compared to the males. The question that we have to ask, though, is it a question of body composition? A bigger engine burns more fuel, and males tend to have more muscle mass, and therefore they tend to do more work, so work performed. Or is it a behavior thing? Were the female participants more conscientious about adjusting their insulin before exercise? And unfortunately, we didn't have the data to really tease that out properly in this particular study. We do, however, know a little bit about how men and women behave when it comes to exercise in people with type 1 diabetes, based on one study here where the questionnaires from the Better Registry were used to compare men and women in terms of their exercise behaviors. And what we found is that men were more willing to eat carbohydrates before and during exercise than women, and that women perceived more barriers to physical activity and exercise. So again, in line with what we would expect to see. A bit of a follow-up to that, and we're still working on putting together the manuscript for this study, is that women were more concerned with weight maintenance in the sample that we were dealing with. And that would make sense then, that they would be less willing to eat carbohydrate before and during exercise if the reason that they're exercising is to maintain their body weight. We also saw differences in activity preferences between the genders, with women having a tendency to go more towards fitness classes and group type of activities, and men having a bit more of a preference for sports. With women, we also see that type 1 diabetes has a profound impact on reproductive health. We see the menstrual cycle is affected, with infrequent periods and longer cycle length being more common in type 1 diabetes. Depending on the study, we can see that up to 80% of adolescents and 40% of adult females with type 1 diabetes will have problems with their periods and their menstrual cycles. The risk of irregularities will increase with higher A1C. So glycemic management is really important in terms of maintaining reproductive health for females with type 1 diabetes. What's also important is, excuse me, is that throughout the menstrual cycle, we see differences in insulin sensitivity. And on the right here, we can see that the luteal phase is associated with lower insulin sensitivity than the follicular phase. What does that translate into in the month? Follicular phase is when you have the period leading all the way up to ovulation, and then the luteal phase is after ovulation for the last half of the cycle. And in particular, this late luteal phase tends to have the lowest insulin sensitivity, so that last week leading into the period. We wanted to see how this would affect female participants who were exercising, because if they're needing more insulin to try to curb those higher blood glucose levels during that luteal phase, it could increase the risk of hypoglycemia during exercise. And I'll just highlight the one box on the bottom here to show what we've found so far. And that's actually fairly consistent with what we thought, that here in the luteal phase, there was a greater need to provide supplements or carbohydrates to our participants because we have safety protocols that we have to follow. And there were more of them that needed that supplement during the during the luteal phase compared to the follicular phase when they came into our lab to do aerobic exercise in the afternoon. A question that I'm starting to look at a little bit more is, what about age? Well, what about it? We actually don't know very much about how age affects glucose responses to exercise. In women in particular, this could be very interesting because with age and menopause, we see a big change in metabolism. And we also see a disproportionate increase in cardiovascular risk amongst women with type 1 diabetes after that menopause transition. And of course, if we go back and look at what the barriers normally are, fear of hypoglycemia, fear of loss of control of diabetes management, major barriers, well, keeping in mind that exercise guidelines that we have right now are based on studies that were mostly performed in young, fit males, that glycemic variability during exercise may be greater in women in general, and in particular in older women, simply because the guidelines were not built in studies that had people like them as part of that research pool. So I'm asking the question right now, are these things appropriate? Are these guidelines appropriate? Are we adjusting insulin appropriately for postmenopausal women? Stay tuned. Hopefully I will have an answer to that question in the next few years, as this is something that we are actively looking at in my lab right now. The right time. The reason for this topic came about due to a disagreement between studies. So if we go back to the one I showed earlier with that slight change in glucose during resistance exercise, this was work that came out of my PhD thesis. A few years later, another group that did pretty much the same exercise protocol, also in people with type 1 diabetes, found an increase in blood glucose levels. And I looked at these studies really carefully, and the only major difference I could find is that the study on the right by Turner et al., the participants were fasting, whereas the one on the left from our lab, we did that exercise at about 5 o'clock in the afternoon, about 4 hours after lunch. And so this brought me to thinking that perhaps fasted exercise would produce different blood glucose responses compared to fed exercise. So I designed a study to look at this, and sure enough, it's exactly what we found. Here, we have afternoon exercise in the closed squares, and we see that caused a decrease in blood glucose with resistance exercise when it was performed at 5 o'clock in the afternoon. If the same participants came back and did the same exercise in the morning while fasting, we see an increase in blood glucose levels. And not only did we see that increase during exercise, we also saw it for several hours after exercise. So while fasted exercise may actually be a really good way to get people active if fear of hypoglycemia is a main concern, because it seems to have a much lower risk of hypoglycemia, it does also have this risk of hyperglycemia. So that's something of which you need to be aware if you're going to be doing that fasted exercise, that there might be a need for some insulin corrections post-exercise in order to prevent those peaks from happening. We also found the same thing with high intensity interval exercise, where if the high intensity intervals were performed in the afternoon after lunch, on average, blood glucose levels decreased. Whereas if they were performed in the morning before breakfast, we saw an increase in blood glucose levels. And here I should really point out that this was a very intense protocol. They were doing a 10-second sprint every 2 minutes, 12 times. The first 3 or 4 aren't too bad. After about 5 or 6, you just don't catch your breath. So we had a lot of very unhappy participants by the end of this study, but it did really show our point very clearly, that intensity might not really be the main factor here, that fasted exercise is what is often causing these increases in glucose that we see in several studies. All right, so some of the key points here, and at the end of this summary, we're going to be opening the floor to questions. So you can open your Q&A box right away and start typing stuff in. We'll get to those as soon as I'm done this little summary. The right therapy, we talked about resistance exercise and interval exercise because these produce more stable blood glucose levels around exercise, but just be aware that they might be associated with more post-exercise lows. And if you're going to be doing a bit of both the high intensity and the aerobic, so weightlifting and aerobic exercise, that the order in which you do them will affect the way your blood glucose changes during exercise. In terms of the right person, it does matter whether you're male or female, and females will have different responses, not just compared to males, but also compared to themselves throughout the menstrual cycle. We also know that barriers are going to be different. And so if recommendations are being given to people with type 1 diabetes to become more active, we might need to be a little more specific in terms of how we counsel men versus women with type 1 diabetes when it comes to exercise. The right time. And that's where fasted exercise comes in. We see that increase in blood glucose levels and highs after exercise. So for those who are really afraid of hypoglycemia, this could be a really good option. But if that high after exercise freaks you out, just be ready to make those insulin adjustments. We do have studies showing that 100% correction bolus is pretty safe and effective, particularly because you have the rest of the day to ride that out before you go to bed. So you don't have to worry about those lows when you're not aware of them. So just a little slide to say thank you to Zainab Momeni, Reed McClure, and Jessica Logan, who are doing a lot of the data collection in my lab right now. Our participants, without whom our research would not be possible, the ADI Clinical Research Unit staff who helps in all of our studies, all of our collaborators, and of course, all of these organizations and companies that have helped fund the research in my lab. And with that, I will leave you with the wonderful University of Alberta logo, and I will head over to the Q&A where I can already see a few questions. Okay, first question. With respect to the spike in glucose with high intensity exercise, I was advised that this could be due to my body entering fat burning phase. I am not sure that you indicated this. I did not see it in the source table you had indicated. Okay, so fat burning during high intensity exercise, fat's not your main source of fuel, but the spike in glucose, if you're getting that during exercise, some people do actually go much higher with high intensity exercise. A lot of that's related to adrenaline and the release of glucose from the liver. And what we also see a bit during exercise and post exercise, because the body does also increase its use of fat. If there's more what we call free fatty acids in circulation, it will cause a little bit of insulin resistance for a certain amount of time, both during and after exercise. So it's a bit of a combination of factors there where high intensity exercise is confirmed. And if you want some clarification on that, feel free to either add another question in the box, or you can also email me for more information there. Kate says, fascinating. I'm going to change up my gym protocol because of this. What I'm hearing is that non-fasted exercise might be the way to go so long as hypoglycemia is avoided and managed. I'm more afraid of hyper, not hypo. Yes, Kate, that sounds like the message that that you should be getting. If that's your biggest fear, is like you just really don't want to go high, then yeah, fasted exercise might not be for you. Doesn't mean morning exercise isn't for you. You could always have that little snack and a little bit of insulin before that morning exercise session, because that would probably change the situation altogether. Although I have to admit, that's something that we still need to look at a little more closely. Okay, this looks like a follow-up. Undergone an intense training program where I achieved, oops, I lost the question because somebody else achieved a really healthy weight and phenomenal diabetes control. Wow, yes, you definitely got down quite a bit. And there's a lot of evidence showing that high intensity exercise is a really effective method of training for weight control and for insulin sensitivity. So I'm really happy to hear that that went well for you. And please keep preaching that, because we want to see more people being more active. And with higher intensity, we see more benefits. So that is a very important message to get out there. The question, okay, in the fasted, the increase in blood glucose associated with not having insulin on board. You mentioned earlier that the insulin caused a decrease in glucose during exercise. That's an excellent question, Jennifer. And yes, you would assume that during morning exercise that there is less insulin on board, which is one of the reasons why it might be safer. But one thing we also noticed is that for our participants who are using insulin pumps, because they did their afternoon exercise about 4 hours after or 5 hours after their lunch, there wasn't really any bolus insulin in circulation, so it was just basal. And they actually had higher basal rates in the morning than they did in the afternoon. So in theory, they even may have had more insulin on board during those exercise sessions in the morning. Yet we still saw that increase in the morning and that decrease in the afternoon. So the other thing that's coming into play there is the fact that in the morning we have these spikes of growth hormone and cortisol. And that's what's related to the dawn phenomenon that some of you may experience, that big increase in glucose before you even get out of bed. And that dawn phenomenon, those higher levels of hormones, promote a lot more fat burning in the body. So fat becomes your main source of fuel. And so when you're using that more during exercise, when there's more fat in circulation, more of those free fatty acids, there can be a bit more insulin resistance. And that's what we think is causing more of that increase in glucose. It's actually related to the growth hormone and the cortisol, not just the insulin. Okay, could you expand on impaired glucagon response in those with long-term type 1 diabetes and those with frequent lows? Will I be able to detect if my glucagon response is impaired? Unfortunately, Noel, no, you have no way of really knowing if your glucagon response is impaired other than having blood tests done while you're hypoglycemic or while you're exercising. So not something that is done frequently. I can't expand a lot on it other than to say that it has to do with having a lot of insulin in circulation to begin with, frequent hypoglycemia, the body stops responding appropriately to low blood glucose. And that's where the glucagon response should be part of what normally happens during low blood glucose, but it kind of stops happening. What we do know is that, for example, in people who had islet transplants, and have completely abolished all of their lows. They never have any hypoglycemia in the months after their islet transplant, that glucagon response comes back. And so the best way to maintain that glucagon response really is to avoid frequent hypoglycemia. And the assumption, I think, with a long-standing diabetes is that there's just been so much hypoglycemia that it's impaired the response. And trying to mitigate that by avoiding hypoglycemia is what's usually recommended. But that's a little bit outside my area of expertise. I'm mostly just focused on the exercise stuff. Okay, Bradford often has a significant glucose rise after hard runs. Typically run 1 to 2 hours after lunch. I didn't show anything about this. No, you're right, I didn't. Serious runner, and this is very predictable with me. Yes. So what I was actually talking about before in terms of free fatty acids causing insulin resistance, that is very similar to what you're experiencing. During running, you're using fat as a fuel source for a very large proportion of your energy. And that means it's being released from your fat stores and traveling to your muscle to be used. But when you finish your run, your body doesn't quite realize that it's done yet, and it keeps releasing fat into circulation for a while after exercise. And that can then cause a bit of insulin resistance, which is why you'll probably see your glucose levels go up and stay up for a while after exercise. It's actually very common after aerobic exercise for a lot of people to see these spikes in glucose about 2 to 3 hours worth after a long aerobic exercise session. So hopefully that answers your question a little bit. But what we do know is if it's earlier in the day, that just insulin adjustments or corrections for those highs is fairly safe, according to the literature. But if it's later in the day, you have to be a bit more careful about how you're treating those. Anonymous attendee, it's just not possible that fasted physical activity increases glucose because no recent insulin. Is it possible? I think I've already kind of addressed that question, that it's not just a question of insulin, but also a question of the growth hormone and cortisol in the morning that cause a little bit of lipolysis, or the use of fat as a fuel source, and a bit more insulin resistance. So that's where we're getting that from. How about having a carb-based snack around 100 calories in the morning before the training? Should that help with the expected highs later in the day? Oh, that's a great question, Marta. We don't know. As far as I understand it, in terms of like basic metabolism, as soon as you put carbohydrates into the body and add some insulin, you are completely changing how the body is going to manage those carbs during exercise, because the carbs that you just put in become the immediate source of fuel. We don't have any studies right now that look really closely at fasted versus fed exercise just in the morning. And that's something that's kind of on my list of like, when I get a whole bunch of money to do a whole bunch of studies, that's the kind of thing that I would very much like to look at. So I wish I had more of an answer for you right now, but unfortunately I don't. Oh, and the next one is, could a little snack in the morning before the training minimize the highs, the highs during the day? Again, there's a good chance that yes, as soon as you put insulin in there before you're exercising, you're changing the way the body's going to handle all of those fuels. Okay, thanks for the presentation. I row 30 minutes 5 times a week. Awesome. I'd like to lose 10 pounds. It's been tough as I often go hypo and have to eat to restore blood glucose. Sounds like I should try reducing insulin by 25 to 50% at meals, 60, 90 to 90 minutes before exercise. That's definitely one approach you could take. It also depends if you are using an insulin pump or insulin injections. If you're on a pump, the recommendation is actually to decrease your basal rate anywhere between 50 and 100%, 90 minutes before exercise, especially because your exercise sessions are what I would call relatively short. You're not doing any marathons. 30 minutes is actually a very safe amount of time if you want to even turn off your pump altogether. And if you are using insulin injections, then what I showed in that diagram was not actually reducing your insulin by 25%. It was reducing it by 75%, so that you're only giving 25% of your bolus with that snack. So that's, again, there are several different ways to deal with that. And it also depends if you're doing it in the morning or in the afternoon. But hopefully that gives you a little bit more information to work with. Best training strategy for weight loss. In terms of timing, type of exercise, could you recommend any articles or books talking about it? In the context of type 1 diabetes, unfortunately, there's not a lot out there that would give you a ton of advice for weight loss. What we do know from the general population in terms of when to exercise is that if you're looking specifically at fat loss, that fasted morning exercise, because fat's that priority source of fuel, that it tends to be a bit more effective for fat loss. And you can see that in the bodybuilding community, for example, that people who are trying to cut, so to basically become really lean before a competition, will do all their aerobic activity before breakfast. One thing to keep in mind is that weight loss is just not all about exercise. There's a famous saying in nutrition that you can't outrun a bad diet. So there's definitely something to be said about the nutrition side of things that needs to come in line with the exercise side of things. And even if you have an excellent diet, sometimes it's the timing of what you're eating and even the portion sizes. It's easy to trick yourself. There's some really interesting research out there around eating behaviors by Brian Wansink. Wansink is out of Cornell University, I think it is, who talks about mindless eating and about the little things that trick us into eating or drinking more than we think we actually are. So if you're looking at something to modify behaviors with food, that's one good way to look at it. And then as far as the exercise side of things, I would say maybe the fasted exercise might be a good approach if it's going to be about fat loss. All right, I've got time for a few last questions here, and Kate seems to be the most eager. If I end up doing a menopausal study, pretty much the right age, should I want participants? Kate, if you're in the Edmonton area, please send me an email. We are right now recruiting for a menopause study. Well, it's post-menopause, so it depends what stage of menopause you're in. But that work will probably be going on for a while. And so we would definitely love to hear from you. All right, last question, reducing basal rates. How far in advance of exercise should we try to reduce basal rates? I do 10 minutes of HIIT before 45 to 60 minutes of resistance and functional strength training. We have evidence to show that with high intensity interval and resistance exercise, that the requirements for insulin reduction are smaller, that you might not need to adjust the basal rates quite as much. And some people actually don't even need to adjust their basal rates at all. It just depends on how much adrenaline you're producing with your activity, and if you have a tendency to go high or to go low. If you are seeing that you're constantly going low, then 90 to 120 minutes before exercise is when it's generally recommended to decrease those basal rates to prevent hypoglycemia. And with that, we are out of time, but it looks like I managed to answer just about everyone's questions. So thank you again, everyone, for attending today. And do feel free to drop me a line if you have other questions that I was unable to answer today.